And I'm going to open up our microscope box. And I think we're doing pretty well. I feel like not only has this been my best webinar, but I am just so thrilled to be in this location. We've never had such a big guest on here. We've had Dr. Vinay Kumar here, but I would probably put this in the same general category. I want to tell you that you people are very, very lucky, because when I took pathology many years ago, 500 years ago, before the microscope was invented, I took pathology, and we did not have to do it in a auditorium where there was a concert going on. We did it in either a smelly lab where there was formalin fumes all around, or a classroom in which there were 300 students. And it was hard to hear and it was hard to see. But now you get the benefit of the digital microscope, infinitely better than your old microscope, and amazing entertainment as well. So let's continue, and we're going to go into now an organ that in which cancers can be seen without surgery or without x-rays, and often even without a microscope diagnosable. So we're going to go to slide number T2, which I think is going to be near the end because it says T on it. So here we are, we're in the S's, and now here's the T's, and here is T2. Okay, and I bet that you're getting better at this. I bet you're getting very good at this. And I think what you could recognize here is, something blue and pink on the top, and then very white and washed out on the bottom, like maybe it's fat. So you're looking at something that has fat on the bottom and some type of thick nodular tumor on the top. And if you don't know what this is yet, I'm going to give you a little sneak preview here of going to the extreme northeast again and showing you something that you should have known by now. We have a stratum corneum, we have a stratum germinativum, we have the prickle cell later, or the stratum spinosum, we have a stratum granulosum, or those granules. So we're dealing with skin. And you know that anything that is keratinized stratified squamous epithelium with skin appendages has to be skin. But we don't see too many clear-cut appendages here. Instead, what we see are what look like nests of these squamous cells and pearls, very much resembling this overlying normal squamous epithelium. But now they are invading into the dermis and the subepidermal tissues. In fact, I'm moving further and further. You can still see these squamous nests and pearls. And now I think we're near the bottom of it, and you're getting into the subcutaneous fat, because you can see some inflammatory cells and fat spaces here. And now we're in an area that is almost 100% fat. So we have a skin tumor that's invasive, and it looks a lot like the squamous epidermis, which is normally covering the skin. But now we have squamous nests and even pearls, because they look like little pearls like we see here, invading. So by now you know that this is not only a squamous cell carcinoma of the skin, but a squamous cell carcinoma that is well differentiated, because it looks very much like the skin, and it even has these differentiated pearls like here and like here. But could this be a squamous cell carcinoma technically of other squamous organs like the esophagus or the oral cavity or the cervix or the vagina or anything else in the body that's squamous, including metaplastic squamous epithelium of the bronchus, which is what we saw earlier today. So this is the second most common primary skin cancer, squamous cell carcinoma. I think I described it well, but I have to apologize for something, because even though it's the second most common cancer of the skin, it is only about 1/10 as common as the most common primary carcinoma of the skin, which is a basal cell carcinoma. Unfortunately, believe it or not, even though the basal cell carcinoma is by far the most common cancer ever in any human being, we didn't have any good slides of it. So either there was never any slide in the collection, or maybe I lost it or something. But at least, or maybe somebody broke the glass to it. So here, let's make this very simple. The two most common, by far, primary cancers of the skin are the basal cell carcinoma and the squamous cell carcinoma. That's the bad news. You want to know the good news? They almost never metastasize. So I never knew of a single person in my 150 years of life that ever died from a squamous cell cancer of the skin or a basal cell. Yeah, they could invade, you saw that, but they cannot metastasize. And those are the two most common things. And another thing they have in common is that they're both highly caused by sun exposure, even though there are other causes of them. And the other, or the third common primary skin cancer, which I haven't talked about yet, but it does metastasize and it is often fatal, is the malignant melanoma. And that's what we're going to see next, because the malignant melanoma is called Derm SC13 in our slide box. So we got, let's go back to the D's. Here's the D, here's the 13, and here's going to be another primary skin cancer. And of course now it's easier to tell that this is skin, because all the way on the left coast here, you could clearly see, at least in this little edge, this is normal skin, textbook normal skin. Stratum corneum, stratum granulosum, stratum spinosum, basal layer. But the other thing you can notice is that as you move towards the area where the tumor is, which we're going to do right now, I think you could agree that there is an increased number of cells. This is a white person, by the way. This is a person that should not have many melanocytes. But you could see that many of these cells now are pigmented. There's a bunch of pigment there. There's a bunch of pigment there. Even the cells that are part of the tumor may look somewhat pigmented. There's a bunch of pigment there. There's a bunch of pigment there and there and there and all over the place there. So we could see that there are nests of tumor cells invading into the dermis, and they also happen to be pigmented. And they also happen to be ugly or nasty because they're big, they're dark, they have prominent nucleoli. And look at, many of them are just, these tumor cells are loaded with this golden brown pigment. Now, even though the pigment just by itself does not have to be melanin, what if they are arising from the cells of the skin that normally have melanin pigment? So these are malignant cells that are loaded with melanin, and I think you probably know already what the diagnosis would be. This is a MM. This is a malignant melanoma. It's easy to diagnose. It's not one of these borderline cases that, you're afraid to diagnose because you might get it wrong. Many of the melanomas are very, very difficult in the early stages to diagnose, and they should be sent to consultants. But this one happens to be very easy. Look, I'm going to show you something on this slide here. This particular nucleolus, which I'm going to zoom in on. Whoops, that's too much. This particular nucleolus here, and here, and here, and here, in here. These nucleoli are so big, they're probably as big as the nuclei of most other cells, and they are pigmented as well. Now, can I ask you a question? Just because you see melanin pigment inside of a cell, could that mean it's a malignant melanoma? No. Why? Because what if there is a skin reaction where the melanocytes undergo apoptosis? Or let's say some of these tumor cells are attacked by some of these immune cells. We don't see too many of them here, but let's say some of these cancer cells are chewed up by lymphocytes. Like maybe you could imagine that might be a lymphocyte, and maybe that is, and maybe that is. But we could find the areas here where there are a lot of immune cells, and let's actually go to them now. I think there was an area where you could see a lot of lymphocytes. Yeah, like here. See this cluster of lymphocytes here? I hope it's in the field of view. Yes, it is. So this is the world's easiest malignant melanoma. No pathologist would ever fear making this diagnosis. And it's also possible that if it's this thick, the patient is in serious trouble, because the prognosis and the survival of people with malignant melanomas is directly proportional to how big the tumor is in its vertical, not horizontal like you see here, but vertical span. So if the pathologist was just to lay a slide rule next to this tumor, and he measured it as maybe like 2 or 3 millimeters, that would be very, very, very serious. Even if the surgeon excises it, and you can see that these margins are negative, yeah, the surgeon can go up to the patient and say, oh, we got it all. However, when you have a malignant process like this that is maybe 2 or 3 millimeters thick or more, or perhaps even goes into the fat, that is usually a very, very, very serious prognosis, because it may have metastasized already. So that third primary skin malignancy, the malignant melanoma, is also, like the other non-malignant melanomas, the basal cell carcinoma and the squamous cell carcinoma, they all have one thing in common. They are common in people that are exposed to a lot of sunlight, especially the so-called dangerous ultraviolet levels. So let's go on to our next case. And now we're also into a whole new part of the body as well. I'm going to go to slide 3975. I don't know if I'll show all three, but at least I'll show two. 3975 looks like it's over, whoops, where did 3975, okay, something got screwed up. Is it backwards? Yeah, 3975, somehow this thing was reversed. 3975, whoops, what's wrong? Oh, I'm sorry, 3795. I'm a little dyslexic today. 3795 is over here. And let's hope that the microscope is working. There we go. And what do we see? Well, we see blue areas and we see pinker areas. And we can also say, probably, without having to convince you too much, that the tumor cells are the darker, bluer cells, but they happen to be growing almost like fingers. In other words, the tumor cells happen to be lining these fibrous structures here. So we would probably call this the papillary growth fashion. And by a papillary growth fashion, it means it doesn't grow flat, but it grows like on little finger-like projections. Okay, that's the best definition of a papillary tumor. And if the papillary tumor is malignant, then we might call it a papillary adenocarcinoma or a papillary transitional cell carcinoma or a papillary carcinoma. If the papillary growth pattern, non-invasive, is benign, we would just call it a papilloma. So let's take a look at one of these little papillary projections here. And let's do this one. And I'm going to ask you a question. Are the cells that line these little papillary structures, is it one cell or is it a layered cell? For example, if you count the number of cells from here to here, it looks like it's 7 or 8, right? So we know it's probably not adenocarcinoma because it's not growing like glands. We know that it doesn't look like it's squamous cell carcinoma because it's not keratinizing. In fact, it's not even differentiating much like squamous mucosa does. Instead, it looks like it is multiple layers. It's not adenocarcinoma. It's not squamous cell carcinoma. So you might call this transitional cell carcinoma. Because if you remember, the transitional epithelium, most of which is in the lower urinary tract, because it lines the calyces, the pelvis, the minor and major calyces, the ureter, the bladder. This is all transitional epithelium, and it looks a lot like this. So this is a papillary transitional cell tumor. Now, could this be of the renal pelvis? Could this be of the bladder? Could this be of the ureter? Yeah, it could be any of those places, couldn't it? But what if I tell you that the slide was labeled as coming from the kidney? Well, then you know it must be coming from the lower or collecting system parts of the kidney, like the pelvis or the major or minor calyces. So this is a papillary transitional cell carcinoma. Now, let's get the terminology more well delineated here. Because transitional cell epithelium lines almost exclusively just the lower portions of the lower urinary tract, from the renal pelvis to the bladder. Because this is a urologic entity, this is also called urothelium, not just transitional cell epithelium, so urothelium. So is another name for a transitional cell carcinoma of the renal pelvis, the ureter, or the bladder? Could that also be called a urothelial carcinoma? Yes. And it's also papillary. So the very, very best term for this entity is a papillary urothelial or a papillary. See, there's a little papilla there. There's a little finger. Sometimes the fingers are so compressed so close together, you can't realize it looks like fingers because the fingers look like they're closed. But look at, there's a nice little finger. There's a nice little finger. There's a nice little finger. This is a papillary urothelial or papillary transitional carcinoma of urothelium. Actually, if you are a histology fan, there are a couple other tiny areas of the body that have transitional epithelium, but for all practical purposes, transitional epithelium can be called urothelium as well. And I'll give you another tip. I've already told you that papillary tumors can either be benign or malignant, but in all practical reality, almost all, and I mean like 99+% of the papillary urothelial tumors are carcinomas. So it takes real guts for a pathologist to call a papillary urothelial tumor benign, because almost certainly the malpractice lawyer is going to send that slide to some big expert at Harvard or Yale or Johns Hopkins, and they're going to probably call it malignant. And then the pathologist at Podunk Hospital in Iowa is going to be sued for not practicing the standard of care. But that's just another story. Okay, that's legal medicine. That's not pathology. Let's go into another pathology case. And we'll go to number 079 now. 079 is going to be right. Whoops. Oh, it's the letter O. It's not the number O. So there's ACHIKLMNO. 79 is over here. It looks like the microscope is a little bit slow, but in the old days it would take a minute to put this glass slide under the microscope and turn on the light and focus and make sure everybody can see well. Here's another tumor. And what can you say about it? Well, you can see the tumor clusters and you can see some connective tissue. But look, at the bottom in the south and in the southwest, you could see what looks like it might be another type of tissue. So let's zoom in on this pinker tissue here. And you could say, yes, whereas this is tumor, this is tumor, this is tumor. At the very bottom here, you got this pinker tissue, which I am going to convince you is smooth muscle. And then you see fat. And then you see perhaps a little lymph node surrounding the fat. I think it's a lymph node. I hope it's not tumor, but we'll look at it in closer detail. So how do you know this is smooth muscle in the middle? Because when you zoom in on it, you can see nice spindly there and there smooth muscle cells. So we have an organ or a tissue that looks like it is smooth muscle, but you could see on one side of the smooth muscle is a big cluster of tumors which invade the smooth muscle. And how am I going to prove that? I'm going to prove that by showing this to you. You could see tumor here. You could see tumor up here. And look at, here's some smooth muscle cells that have been invaded. So let me ask you this. If this was the bladder, which it is, and this is also a transitional cell carcinoma of the bladder, although it's not as papillary as the other one that we saw. If this was a bladder, and we could see that the tumor invades into the bladder wall, do you think that possibly that the surgeon might want to take out the bladder? Because if the tumor only involved the mucosa, he could maybe remove it by cystoscopy and then keep a close eye on the patient with multiple cystoscopies. But if this tumor has now invaded deeply into the bladder wall, in fact, let's take a look at that lymph node. Maybe that lymph node is not just lymphoid tissue. Maybe that lymph node has tumor in it too. Oh my God, it does. That's not just lymphocytes, folks. That's tumor. So not only is it invaded the bladder wall, but it's metastasized to a regional lymph node. So now it's very likely that if the tumor invades the bladder wall, the surgeon is going to want to take out the whole bladder, or what they call a radical cystectomy. If the papillary tumor involved only the inside or the lumen or the mucosa of the bladder, they might just remove it or perhaps give it some type of other treatment and not remove the entire bladder. But this bladder needs to come out. And that's why we got it. Because it did come out and it got into the hands of the University of Iowa, and then they took some very nice pictures of it. Okay, well, we've done transitional cell carcinomas that are papillary. We've got one that's invasive. Let's go to another area here, which is going to be kind of interesting. Now we're in another part of the body, and it'll be slide 4390, which is going to be approximately over here. And let's see how fast our microscope is working today. Oh, it's working fast now. And my God, all you see is one big clump of cells. Well, what if I told you that this one big clump of cells was almost an entire testicle? So there's a testicular tumor. Okay, how was it detected? Maybe by palpation, most likely. But let's look at it in bigger detail, and it looks like most of it looks like it's heterogeneous. It looks like it's just irregular clusters of cells, doesn't it? It doesn't look like they differentiate into glands. They're not papillary, and they might not even be epithelial cells, because does the testicle normally have epithelium like glands or squamous? No, it doesn't. So most of the tumors of the testicle are not carcinomas. Most of the tumors of the testicle are from the cells that are indigenous to the testicle, which are the germ cells. So most of the tumors of the testicle are germ cell tumors. And there's 3 or 4 major types, but this is probably the most common type of testicular malignancy. It happens to be called a seminoma. And you're just going to have to take that on faith. But the one thing that you don't have to take on faith is to look at these cells. For the most part, almost all of these tumor cells look like each other. They look like they're primitive germ cells, okay? I know I might be pushing that a little bit. So most seminomas look like these primitive germ cells. Now, I want to show you another feature of many seminomas, but it doesn't have it quite well in this one. But if you notice that this seminoma not only has predominantly these nucleated, primitive, non-differentiated cells, like all of these cells here, look like all of these cells here, but occasionally, 1, 2, 3, 4, 5, they're occasionally stippled with normal lymphocytes. And remember, we said that if you see lymphocytes in a tumor, especially abundant amounts of lymphocytes, that means that your immune cells are trying to destroy the tumor. Okay, these are probably CD8 T cells. And let me ask you this. If this seminoma had 90% lymphocytes and 10% primitive germ cells, do you think that prognosis would be better than this particular seminoma, which has 90% germ cells and just a few stippled lymphocytes here and there? This seminoma does not have many lymphocytes, so it is probably not going to do as well as a seminoma that has 90% lymphocytes. And this is probably the most common type of primary testicular cell malignancy. So the germ cell tumors of the testicle are the predominant form of testicular tumors, and they are usually malignant. And if you remember, there is no regional inguinal lymph nodes that drain the testicles. They are basically drained where they originated from, in the retroperitoneum. So the retroperitoneal nodes, the periaortic nodes, might be the first place that they metastasize after they travel up the spermatic cord. So let me show you another testicular tumor. I want to point out something very important, because we'll be dealing with this extensively when we go to our chapter on male. It's going to be slide number 3678. And slide 3678 is over here. And what if I told you again that this was another testicle? And you can see some connective tissue and blood vessels here on the right. And then you can see these darker and perhaps more irregular cells occupying the majority of this field. And then you just want to blow it up, which is what we're going to do. Now, this is going to be a tough case. Made sure that not all the cases that I gave you today were easy, but these cells here, they look kind of glandular, but remember, there are no true epithelial cells normally within the testicle. However, the Sertoli cells, or the sustentacular cells, or the cells that you see predominantly in certain parts of the testes, look like they are epithelial. So I'm going to show you this tumor composed of Sertoli cells. And can I ask you an honest question? Cells do not look terribly malignant. Oh, they look glandular. Some of them are a little bigger than others. But I want to demonstrate a point here. I told you that most of the germ cell tumors of the testicle are malignant. The Sertoli cell tumors and the Leydig cell tumors are not germ cells. They support the seminiferous tubules, and they have a variety of other functions like hormonals, testosterone. But the Sertoli cells of the testicle and the Leydig cells of the interstitium between the seminiferous tubules are not germ cells. So why am I saying that? I'm saying that because a good general principle for you to remember is that most germ cell tumors of the testicle are malignant, but most non-germ cell tumors like this are benign. And how do you know these are Leydig cells? You say, well, how do you know this isn't metastatic lung cancer or transitional cells? Because you could stain it with antigens that are specific for Sertoli cells. I will admit, when you look at this by itself, you don't really know what kind of cell this is. But these are Sertoli cells. And if you go back to a normal testicle and look at Sertoli cells, you would see a lot of similarities between this tumor and normal Sertoli cells, which means it's probably benign. So what am I leading up to? Germ cell tumors in the testis are malignant. Non-germ cell tumors in the testis are usually benign. They may be hormonally active, but they're benign. Let's go to another part of the body now. That's the analogy to the testicle, and that's going to be the ovary. And we'll go to another principle here. We said that most tumors of the testicle are germ cell tumors, and the germ cell tumors are mostly malignant, and the non-germ cell tumors are mostly benign. But what about the ovary? You think it might be the same thing for the ovary? Well, in a way, but most of the tumors of the ovary are not germ cell tumors. Most of the tumors of the ovary are epithelial-looking tumors. And I'm going to show you something here called 4415, which is going to be coming up very soon. 4415. And you're going to have to believe this is an ovary, because what it actually is, it is an ovary, but it's filled with these clusters of cells. You don't see normal follicles, you don't see normal stroma, you don't see corpus luteum, you don't see corpus albicans. Instead, you see these dark clusters of cells replacing and invading the substance of the ovary. So even before we look at the cells to determine what they look like, or if they're epithelial or non-epithelial, we will tell you this already looks like an ovarian cancer. Let's zoom in on this area. What can we say about it? Well, we can say up here, it looks like it's kind of papillary. But rather than transitional cells or squamous cells lining these papillae, it looks like there are single layers of columnar cells or glandular cells, or it's not stratified. And to prove that, we're going to look at this one particular papilla, and it has a single glandular type of covering. So we can already say that it's malignant and it's papillary. What else can we say? We can say, well, it looks like the tumor cells are not mucinous, so this ovarian tumor is probably not going to be secreting mucin, but it may secrete a non-mucinous thing like a more watery or serous. So, thank you. We were just interrupted by a telemarketer. If I ever find out who's behind this, you know I'm going to kill them. But let's take a look now at a less differentiated area of this papillary adenocarcinoma. And you can see an area it's compressed, so you can't make out the papillae that well, but there is one, there is one, there is one. Let's take a look at the cells themselves. What can you say about the cells themselves? Well, you can say that they are pleomorphic, they are irregular, they are big, they are small, they are dark. They have all the features of a malignancy. And because of the location of the ovary, it's possible that if these tumor cells went beyond the confines of the ovary, like beyond this point here, that they would go into the peritoneal space, or ascites. So why am I saying that? Why I'm saying that is if a woman comes in and she has an ascites, and it's not because of liver disease, but you stick a needle in there and you do a paracentesis, and you see that she has tumor cells, malignant tumor cells, inside of the acidic fluid or the watery fluid in the peritoneal cavity, most likely they're coming from the ovary. Here, let me say that a little bit more easily. Malignant ascites in women is usually due to primary ovarian cancer. And because we have a papillary epithelial thing, most of the malignancies of the ovary are not germ cell tumors. They are epithelial-like tumors. Now that I said that, I'm going to be a little bit of a wise guy, and I'm going to show you another ovarian tumors. And this is going to happen to be the most common tumor of a young woman. A solid or cystic common tumor of a young woman, number 4423. I think it's 23. 4423. And you're going to say, oh, Monastic must be crazy. He told us he's going to show us ovarian tumor, and that stupid idiot is showing us hair and epidermis and sebaceous glands. So how could hair be inside of an ovary? Well, this is a teratoma. This is technically a germ cell tumor because it's derived from multi or totipotential cells, and this particular type of tumor is not only cystic, but it has both epithelial and glandular and hair and connective tissue components and blood vessels. So you know it's a teratoma, and it's cystic, and it contains, as you can see, these are all sebaceous glands emptying into these hair follicles, which is right here. So you could probably call this a benign cystic teratoma. In fact, you know it's benign because most of the cells are differentiated into normal, recognizable structures, but the old name for this tumor was called a dermoid cyst, emphasizing the point that it's just a cyst. And when you see the word cyst, sometimes you don't think that's a real neoplasm, that it's just a cyst. But this one is a real tumor. It's a teratoma. It's benign. And a cystic teratoma or dermoid cyst is the most common benign tumor of the ovary of young women. And it's kind of funny because when you look at this at surgery, you may accidentally rupture the cyst, and you're going to see all of this greasy hair, sebaceous material in your hand. Or when you cut it open pathology, it looks like it's a hairball because it has nothing but this fatty, sebaceous type substance, yellowish junk, and hair. And sometimes they have other things like teeth or thyroid tissue or brain tissue or retina. Because remember, this is a teratoma. Technically, it's derived from cells which theoretically can differentiate into almost any type of recognizable human tissue. Not just epithelial, but also things like smooth muscle or bone, okay? So let's move on to our very last organ. And let me look at the time because I do not want to keep you late. And we do have, I think, a good amount. Yeah, we have enough time to show you the rest of the cases, so we will. And I'm going to turn off the sound on my phone, which is what I should have done already. And I just love to hear from telemarketers in the middle of a webinar. So let's go to the last and perhaps the most important organ of the entire human body that can get cancer. And remember, any part of the body, if you remember, they're indigenous cells. The cells that give rise to these indigenous normal cells can also mutate to form uncontrollable, unregulated masses of tissue, which we call tumors or even cancers. So the last thing we're going to be looking at is a brain, okay? And we got about 4 cases I want to show you on brain. And the first one will be 4065, which I think is going to look like it's right here. And you're going, whoa, what the hell is this? You say, this can't look like anything. It just looks like smeared junk. Well, I got news for you, folks. It mostly is smeared junk. Why? Because whatever this tumor is, it's growing very, very fast, and it's outgrowing its blood supply. So most of the tissue here, especially this lighter tissue on the right, is nothing but necrotic tissue. It's not recognizable. It has no cellular recognition. Look, it's necrotic material, and it looks like it is almost liquefied. So this is the liquefactive necrosis that you hear about, of the type of necrosis you see in the central nervous system. Liquefactive necrosis, by its name, which means it has liquid or water, which means it has more H2O, which means it has more H, which means it has more protons. So it may look up as very, very bright signals on MRI. But take a look at these cells now. Here is the necrotic part of the tumor on the right, and here's some cells here on the left. So what can you say about these cells on the left? Well, first of all, they look like hell, okay? They're very, very dark. Here's one that has a mitosis from hell. It's very, very irregular. There's another mitosis. That nucleus looks like, somebody put it through a meat grinder. This is a very, very pleomorphic tumor. It's growing so fast that large parts of it are necrotic. And I'm going to give you another adjective which we have used before. The adjective that we have used before is the word palisading, because at the interface between the necrotic area and the viable area, you can see that the cells are often lined up like little soldiers, like in a row, like you see normally with basal cells. Or the word palisading means that they're all kind of standing up in a row. So you see palisading, you see necrosis, you see extreme pleomorphism. And I'm going to try to find something else here, because this is another feature of the highly malignant brain tumors. And if I could find it, I'll show it to you. And if I can't find it, oh, maybe here. Yeah, maybe here. Do you see this little circular cluster here? It looks like it's a little bit palisaded, but it seems to be more viable growing around this little circular here than it is away from the circular area. This is what you call a perivascular growth pattern, because the viability of the tumor cells is the most viable when the part that's closest to the blood vessel, which I believe this thing may be because it looks very circular. So let me see if I could prove that or not. Oh, yeah, I think I might convince you that this is maybe at once a blood vessel. So what does that mean? It means that tumor cells, which grow very rapidly and are very malignant and have a bad prognosis, are more likely to be seen viably surrounding the blood vessels that feed the tumor. And eventually, the further you move away from the blood vessel, the more necrotic the cells become. That's why they call it the perivascular growth pattern. So let's summarize this thing. It's a brain tumor. It's very highly pleomorphic and malignant. Not only does it have large areas of necrosis, but it has perivascular necrosis as well, away from the blood vessel. And it has what you'll see here is lined up as palisading. This is the classic 4 or 5 descriptions of the most common type of highly malignant brain tumor, which is called the glioblastoma multiforme. Now you think, well, why would you use such a crazy long term, glioblastoma multiforme? We all know that most brain tumors are not tumors of the actual neurons, because neurons, a mature neuron, cannot divide. But most of the primary brain tumors are tumors of the cells that support the neurons, the glial cells, the astrocytomas, the ependymal cells. So most brain tumors are not tumors of the neurons, they're tumors of the glia. So they're called gliomas. And a glioma can look well differentiated. You would call it a low-grade glioma. And then you have gliomas that are very highly undifferentiated, like this one, very malignant, which you call the high-grade gliomas. And another name for a high-grade glioma is a glioblastoma multiforme. These brain tumors are so malignant that once you have a diagnosis of them, because you have all the classical features of high-grade malignancy, that they are usually dead within 1 year if you don't do anything. If you do proper radiation and because of its location, chemotherapy, you may extend that to years. But a glioblastoma multiforme, I hate to say it, but is usually fatal. So that's the worst form of the most common type of brain of glioma. I'm going to show you a glioma now that is not looking so horrible, which means the cells may actually look like normal glial cells. And that's going to be case number 4064. So 4064 looks like it's over here. And you can already see that it's largely not necrotic, but you can also see when you look closely at the cells of the primary brain tumor, these are not metastatic adenocarcinoma cells. This is not squamous cell. These are cells which kind of look like normal glial cells, except for one thing. They are somewhat pleomorphic, but they're not necrotic. They're not palisading. They don't have the perivascular growth pattern. So this would be a primary glioma brain tumor that is not high grade. Maybe you would call it intermediate grade, or call it whatever you want, but it is going to behave better than a high grade glioma that we saw and we called glioblastoma multiforme. Okay, here's going to be another maybe easy brain tumor. Remember, most brain tumors are of the glial cells. They are not of the neurons. So what are the glial cells? Well, you have astrocytes, you have oligodendrocytes, you have microglia, you have ependymal cells. So let's take a look at case number 927, which is going to be right here. And you're going to say, well, this showed up as a mass on CT. Patient had clinical symptoms. We don't know what part of the brain it's from, but it does not look like normal brain. And in addition, another thing you can say almost right away from looking at it, which may have been evident from the CT scan, because the CT scan is very sensitive to calcified areas. The one thing you might say is that there's a lot of little calcifications in this tumor. There's a lot of cells, yeah, but there's a lot of areas where it calcified. So on CT, this may have looked like a very, very calcified tumor. Now here's a part of the tumor here which does not look so terribly calcified, but you can still see little calcifications. You can also see hemorrhage, acute hemorrhage within the tumor. But let's look at this part over here, which is an average part. I'm going to blow it up. And what can you say about these tumor cells? What you could say about these tumor cells is that they all have a little halo around them, a little clear zone. Now, what type of normal glial cell normally has a little halo around it? Because the halo is fatty tissue, and myelin is fatty tissue. So, what type of brain tumor, what type of brain glial cell is very highly myelinated? You're right. It's the myelination cells of the central nervous system, the oligodendro cells. So what does that mean? It means this is an oligodendroglioma. And now you know why it's called that. And you also know this is the end of our discussion for today. And you may also think that Yulia went back to her piano because she's going to do another Chopin piece to end us. And we probably will get out of here within the next 5 minutes. But I know you're not anxious to leave because you want to hear one last beautiful song from Yulia. So I'm going to start by focusing in on some of the beautiful flowers on one of her piano. And Yulia, can you close the webinar for us?
Sure.
Yulia, stay where you are, but I want you to look at my hand and say 3 words. I want you to say rock on buzzards.
Rock on buzzards.
Thank you. And may all of your days be magnificent piano concertos. Bye-bye.